Hi everyone, and welcome. My name is John McCullough. I'm a graduate student in the Applied Nutrition program at the University of New England. Today, I will be discussing my systematic review on the impact of daily vitamin D supplementation on bone mineral density in postmenopausal women. Let's get into it. So just a quick overview of the objectives. I will introduce the role and importance of vitamin D in the human body, as well as how it can be consumed and absorbed. I will also discuss the population of this review, postmenopausal women, and why they are at risk for negative bone health outcomes, which will lead into my research question. This will precede my methodology for searching and selecting various research articles that will be referenced throughout this presentation, where we will then discuss the findings of those articles. From there, I will talk about the conclusions, including strengths and limitations that can be drawn from the varying trials and their implications. And I won't go over them, but the references used throughout this presentation will be available at the end. To start, what is vitamin D? Put simply, it is a fat-soluble vitamin that is absorbed in the small intestines. It can be obtained by consuming food. Fish is an excellent source of vitamin D, or supplements, but it can also be absorbed when UV rays from sunlight hit your skin. It works in harmony with other micronutrients, such as calcium, in that it promotes the absorption of calcium in the gut. It is also needed for bone growth and bone remodeling. Vitamin D deficiency occurs when there is lower intakes over an extended period of time, possibly leading to an individual's bones becoming thin and brittle. Deficiency is described as having a serum 25-hydroxyvitamin D, or 25-OHD, level less than 12 nanograms per milliliter. For females that are greater than 50 years of age, it is recommended that they consume 600 to 800 IU per day. As women age, the incidence of decreased bone mineral density becomes more common. While a lack of vitamin D is common, it is also a neglected health problem. It is also associated with skeletal muscle, cardiovascular disease, diabetes, and menopausal symptoms. The lack of estrogen production hinders calcium absorption in the small intestines. This can lead to incidence of osteoporosis, and if they are vitamin D deficient, it can further reduce bone mineral density over time. While we understand how postmenopausal women have increased risk for negative bone health outcomes, this systematic review aims to investigate vitamin D supplementation's role in affecting bone mineral density. To be more specific, among postmenopausal women greater than or equal to 50 years old with vitamin D deficiency, how does the addition of a daily oral vitamin D supplement of 1,500 to 2,000 international units affect bone mineral density when consumed for at least 1 year? Before beginning my search, I create a set of inclusion and exclusion criteria to help decide which studies would or would not become part of the systematic review based on my research question. Any women that were younger than 50 years old were excluded. They had to be free-living and community-dwelling individuals that were otherwise healthy apart from their vitamin D deficiency. So, if they were in a hospital or a nursing home, it would not be part of the review. I wanted the studies to have minimal bias, controlled conditions, show causality, and be replicable. As randomized controlled trials are considered the golden standard, they made the most sense over non-controlled trials, case studies, prospective or retrospective cohort trials, and others. A minimal dropout rate was desirable, with at least 10 patients per group. Trials within the last 5 years were the most desirable, but within the last 10 years was acceptable. If the language was not in English, it was excluded to avoid translation mistakes. And if the supplementation trial didn't last at least 1 year, then it was also excluded. The primary databases that were used to search for appropriate trials were PubMed and CINAHL. as I was most familiar with their layout and have had success in the past when searching for other literature. The search terms I used were a mix of medical subject headings, also known as mesh and non-mesh terms. They included adults, aged, vitamin D deficiency, dietary supplementation, vitamin D, and bone mineral density. The total studies that were screened amounted to 134. After eliminating studies for duplicates, available full texts, interventions being outside the criteria range, and more, a total of 4 studies were left over to conduct my systematic review. The following slides will discuss the research findings from the 4 studies in the systematic review. In this randomized, placebo-controlled trial, titled Effects of Supplemental Vitamin D on Bone Health Outcomes in Women and Men in the Vitamin D and Omega-3 Trial, LaBeouf et al. Investigated the effects of a daily oral vitamin D3 supplement in the primary prevention of cancer, cardiovascular disease, and bone health outcomes. The trial consisted of older adult females, greater than or equal to 55 years, who are vitamin D deficient. 771 in total, and had a mean age of 63.8. Patients were considered eligible for this trial if they were not on bisphosphonates within the past 2 years or on other active bone agents within the last year. 388 participants were randomized into the treatment group and received 2,000 IU of vitamin D3 and or 1 gram of omega-3 fatty acids per day for 2 years. The control group, consisting of 383 randomized participants, received a daily vitamin D placebo. Fasting blood samples were collected at baseline and year 2. In the treatment group, 25 OHD levels increased by 46.2% by the end of the 2 years. There was no increase in bone mineral density or reduced bone loss at the spine, femoral neck, total hip, or whole body compared to the placebo. Changes for bone mineral density were at less than 1% with a p-value of 0.062. In the placebo group, 25 OHD levels remained the same by the end of the 2 years, with no significant change to bone mineral density. In the end, while daily oral supplementation of 2,000 IU vitamin D3 and or 1 gram of omega-3 fatty acids increased 25 OHD significantly, there were no significant changes to bone mineral density. For this randomized controlled trial, the effects of vitamin D supplementation on frailty in older adults at risk for falls, Kai et al. Investigated the effects of a daily oral vitamin D supplementation on the frailty of older adults. The trial consisted of community-dwelling, aged adults greater than or equal to 70 years who had a vitamin D deficiency. Participants totaled 688. The mean age was 77.1, with 44% of the subjects being females. Patients were excluded if they had cognitive impairment and the use of personal vitamin D supplements greater than 1,000 IU per day or calcium supplements greater than 1,200 milligrams per day. 349 participants were randomized into the high dose group and would receive either 2,000 IU per day or 4,000 IU per day for 2 years. 339 participants were randomized into the control group and would receive 1,000 IU per day for 2 years. All participants had clinical visits at baseline 3, 12, and 24 months after randomization. Patients in the higher dose group that received 2,000 IU per day for 2 years had double the risk of worsening bone frailty status. The hazard ratio is a valuable measure for comparing the risk of events between groups in survival analysis studies, providing insights into the relative effectiveness or risk associated with different interventions. Anything above 1 suggests an event is likely to occur, and the hazard ratio was 1.89 with a confidence interval between 1.13 and 3.16 with a p-value of 0.015. So among community-dwelling aged adults with vitamin D deficiency, vitamin D supplementation of 2,000 IU per day for 2 years did not demonstrate a beneficial effect on bone frailty status. However, it is possible that this may be the result of a type 1 error, and replication of the trial's findings is warranted. In this randomized double-blind placebo-controlled trial, effect of increasing doses of vitamin D on bone mineral density and serum N-terminal telepeptide in elderly women, a randomized controlled trial, Smith, Gallagher, and Jones investigated the effects of a daily oral vitamin D3 supplementation on bone mineral density in older women with a vitamin D deficiency. The trial consisted of aged women 57 to 90 years. Participants totaled 273. The effect of dose on bone mineral density was a predetermined secondary outcome. Exclusion criteria were any significant disease or medications that affect calcium and bone metabolism. This may include significant health problems, cancer within the past 10 years except for skin cancer, previous hip fracture, uncontrolled type 1 or type 2 diabetes, drugs interfering with vitamin D metabolism, such as phenytoin and phenobarbital. All participants were randomized equally into 7 groups with different vitamin D3 doses: 400, 800, 1,600, 2,400, 3,200, 4,000, and 4,800 IU per day, and a placebo group. Fasting blood samples were collected at 3, 6, 9, and 12 months, and serum 25-OHD were collected at baseline, 6, and 12 months. Bone mineral density was measured using dual energy X-ray absorptiometry. In any of the treatment groups, there was no significant difference in bone mineral density after 12 months. Total body, the p-value was 0.30. In the placebo group, there was also no significant difference in bone mineral density after 12 months. The total body p-value was 0.57. It was concluded that among aged women 57 to 90 years with vitamin D deficiency, vitamin D3 supplementation between 400 and 4,800 IU per day for 12 months did not significantly affect bone mineral density. Mason et al. Conducted a double-blind placebo-controlled randomized trial titled Effects of Vitamin D3 Supplementation on Lean Mass, Muscle Strength, and Bone Mineral Density during Weight Loss, a double-blind randomized controlled trial. They investigated the effects of a daily oral vitamin D3 supplementation on changes in lean mass, muscle strength, and bone mineral density on older women with vitamin D deficiency and a body mass index greater than or equal to 25. The trial consisted of post-menopausal women 50 to 75 years. Participants totaled 218. They were excluded from the trial if they were currently taking more than 400 IU of vitamin D from supplemental sources, had diagnosed osteoporosis or a T-score of 2.5 SDs or more below the mean of a reference population, which was healthy young adults at peak bone mineral density, as measured using the dual energy X-ray absorptiometry, or any other significant health problems. 109 participants were randomized into the treatment group to receive an oral supplement of 2,000 IU per day for 12 months, while the other 109 participants were randomized into the placebo group with a matching dose of sunflower oil. All measurements were taken at baseline and 12 months. Women in the treatment group experienced a significant increase in 25-OHD levels after 12 months, while the placebo group saw no significant increase. Serum 25-OHD increased by a mean of 13.6 nanograms per milliliter, in the treatment group and decreased by a mean of 1.3 nanograms per milliliter in the placebo group over 12 months. The p-value was less than 0.0001. Changes in the bone mineral density of the spine and femoral neck were not significantly different between the two groups. They were negative 0.02 grams per square centimeter versus negative 0.01 grams per square centimeter with a p-value of 0.01. In the end, among postmenopausal women aged 50 to 75 with vitamin D deficiency, vitamin D3 supplementation of 2,000 IU per day for 12 months did not significantly affect bone mineral density. Now, if we were to look at the overall picture of these 4 studies, they all had a population that consisted of older adult females greater than or equal to 50 years of age, and they all had a vitamin D deficiency. The total number of participants across the 4 randomized controlled trials was 1,950. The interventions consisted of 2,000 IU per day for 2 years, 2,000 or 4,000 IU per day for 2 years, 400 to 4,800 IU per day for 1 year, 2,000 IU per day for 1 year, and each control group took a placebo, with the exception of Smith, Gallagher, and Jones's control group that took 1,000 IU per day. Every single trial that was reviewed showed an increase in 25 OHD levels by the end of 1 or 2 years. However, they all showed that, regarding bone mineral density, daily vitamin D supplementation did not lead to significant improvements in bone mineral density. Based on the findings from the 4 studies, it can be concluded that daily oral vitamin D supplementation of 1,500 to 2,000 IU for a duration of at least 1 year does not significantly impact bone mineral density in postmenopausal women aged 50 years and older with a vitamin D deficiency. While evidence shows that supplementation improves 25 OHD levels, there is limited proof of a significant effect on bone mineral density. These findings suggest that an alternative strategy must be implemented to meaningfully impact bone mineral density in postmenopausal women with vitamin D deficiency. The conclusion statement, as aligned with the review findings, gets a second-tier fair grade. It shows moderate confidence in its findings, and this will become clear as we discuss this review's strengths and limitations. This systematic review has a few notable strengths. For one, there is a large sample size. Some of the studies include a significant number of participants. This enhances the statistical impact of the findings. All of the studies were randomized controlled trials, which is reliable in clinical research because it has minimal bias, controlled conditions, they show causality, and can be replicated. For longitudinal design, each study followed the participants for at least 1 year, which allowed for the assessment of the long-term effects of vitamin D supplementation on bone mineral density. Not all reviews are without their limitations, however. Here are the 3 that most stand out: diversity of study design, variability in the design and methodology across the 4 studies may actually introduce some bias and make synthesizing results challenging. Baseline vitamin D levels. There is a variation in vitamin D levels at baseline among participants, and that could impact the efficacy of supplementation and make comparisons challenging. And finally, compliance. There may have been challenges with compliance among participants and their supplementation, and that may affect the accuracy of the results. Ultimately, the implications come down to research and practice. For research, there was no significant improvement in bone mineral density in oral vitamin D doses ranging from 400 to 4,800 IU per day for up to 2 years. Future research can use this information to help design their studies. Future research should investigate the underlying mechanisms behind these observed outcomes. Understanding how vitamin D interacts with bone metabolism could provide insights into personalized interventions. Practice. Health professionals should consider the lack of significant impact on bone mineral density when prescribing vitamin D supplementation to postmenopausal women with a vitamin D deficiency. Instead, perhaps they should consider a more personalized approach based on age, baseline levels, and bone health status. Health professionals should emphasize a more holistic approach to bone health. This may include the encouragement of a balanced diet rich in calcium, regular weight training, and other lifestyle factors to complement vitamin D intake. Here are the references used for this systematic review presentation. Thank you for your time, and I hope you enjoyed.